it's quite difficult to treat this problem. It's a video, it not move. Okay. Because the deformity is quite hard to operate on this kind of patients. You see, I think no matter how young is the AS patient, bilateral hip fused, that's an indication for total hip replacement. So I have finished such an operation on 43 patients. I use the Watson-Jones approach because it's easier to get a soft tissue release. And we did a follow-up for 6 to 120 months. So let's see the result. Above is the patient before the operation and after the operation. Just 1 day after the operation, the patient can move freely, almost freely. And 6 months later, 8 years later after the operation, that's the follow-up for 8 years. See this patient. This patient cannot lay down normally on bed. And this is after operation. Bilateral hip replacement. This young guy. You see, if you want to move the foot, the whole body will be moved. And this picture shows that I have finished this side. We give the patient bilateral ceramic on ceramic hips. And 3 days after operation. Another patient. We have a lot of such patients. Okay. The radiological follow-up showed that no processes migration was found in any case at the last follow-up time. There are 39 patients that can take care of themselves in their daily life. But there are another 4 patients that need some help, not much help, in the daily life. Just 1 day after operation. See this one. Fused from the head to the knee. He walked like this before the operation. And bilateral hip replacement. 1 year after the operation, he can walk like this. She had a too much easier life now. One year after operation. So I used the Watson-Jones approach. I didn't use the posterior approach because with the posterior approach, it's very difficult to release the anterior soft tissue. In some patients, you have to release the soft tissue. And don't cut too much about the femoral neck. Otherwise, you have to re-implant the bone back. And you have to confirm where is the center of the acetabulum. And sometimes I will fix the cup onto the remaining of the femoral head. You can see this patient. There's still some remain part of the femoral head because of it's fused with the it's fused, so it's okay. We will have a difficult time for dripping because you cannot separate the patient's legs apart. And for some patients, you have to make a release of the soft tissue anterior to the hip. And be careful about nerves and vessels. Do not stretch the hip immediately after the release. Otherwise, perhaps the nerves and the vessels will be damaged. And for the rehabilitation, you have to teach the patient how to use their muscles, because they have perhaps more than 10 years they didn't use their muscles. So they don't know how to take a walk with the normal hips. So for the anesthesia, if you have the skill to perform the operation, you have to ask your anesthetist, ask them if they have the ability to give the patient anesthesia, because the patient's neck are fused like this. So ask your anesthetist to ready to make a torture intubation through the nose. That's very difficult. And during the operation, please be careful. I made a fracture like this. You cannot fix the fracture with a plate and screws. The bone is very soft. And for the kyphosis and hip fusions, which one should we perform first? Usually the hip first. But for some patients, they have inefficient respiration function. So which one first? You have to discuss with the spine surgeons. Thank you very much.